Hello friends, we all know that distal femur fractures, especially those with articular involvement, are complex injuries. But the problem becomes more complex when these fractures are quite low. Like the one you are seeing in this x-ray, the medial condyle appears to be split. So I'll be starting with a case presentation. So this was a 21-year-old male who had sustained injuries because of road traffic accident, and there was direct impact on the knee with flexed position, and there was an open wound of 1 centimeter size without any other issues. So we went for x-rays. So this was the first AP view we got done, and this was the lateral view. While in this AP view we are not able to clearly see what is happening, but we are definitely able to see that there are multiple fragments. While in this lateral view we can see there are multiple fracture lines on one of the condyle. You see the split is here, the split is here, the split is here, and on this condyle it appears to be a bit simple. And whenever we are not able to see the fragments clearly, it's better to get an AP view in a traction mode. That means the attendee of the patient has to give some traction so that the fragments come in near appropriate alignment. Then you will be able to see the fragments more clearly. So the x-rays are never sufficient. Whenever we are addressing the articular injuries, we have to get a CT also. Now we are moving from the lateral side towards the medial side. This is the lateral condyle of tibia, and this is lateral condyle of femur. The lateral condyle of tibia is convex, that's why this cut belongs to the lateral side. And here we see the fracture of the lateral condyle is bit simple, kind of Hoffa's component we have here. And as we go towards the medial side, first in the notch part, here we have extensive comminution in the notch. And as we go more medially, we see there are multiple split fragments, like you see here, one large fragment here, another small fragment here, another small fragment here, and another large fragment posteriorly. And definitely comminution is there on the articular side as well as extra articular side as well. So these were the sagittal cuts. Now we go towards the coronal cuts. Now this is starting from the anterior to the posterior. This is one is anterior, again the similar picture, the comminution on the notch part, medial side, and lateral side appears to be a bit simple. And on this cut, that means in the central part of the knee joint, we again see the comminution on the medial side, the comminution on the notch part, and the lateral side appears to be simple. And as we go more posteriorly, we are able to see the posterior condyles. The posterior condyles appears to be somewhat intact. That means they are not comminuted. And on the lateral side, it is very clear it is not comminuted, but again there is comminution in the notch part. Now we go towards the axial cut. Again the same picture. We see a large fragment of the trochlea which was actually continuous with the proximal segment because it is a low fracture. Here you see this fragment is continuous with the proximal fragment, so it is not fractured. In axial cut we are able to see it because it is separated from the remaining part of the condyles. And this part is the medial side. You see comminution is there, some kind of impaction is also there. You see this white density is because of the dense impacted bone. And there is comminution on the notch part. And in this cut also we are able to see the similar findings, but you see here now we have gone bit down. Now we are able to see the comminution in the notch part and in the trochlea. We are below the intact fragment of the trochlea. That means we are somewhere here. That means we are lower to the part which was intact. So extensive comminution is there in the notch part and on the medial condyle, while there is no comminution on the lateral side. So whenever we are planning surgical fixation of these fractures, always try to get a 3D image, because the bone you are operating will present to you like this. It will not be in form of 2D or X-ray. So you see here there is extensive comminution in the notch part as we see here in the 3D cut. This part is the trochlea which is still intact and part of the proximal fragment, and this is the void that the fracture has created. And as we see from the sides, the medial condyle, here you see there is extensive comminution which we had seen in the other cuts. There is some comminution on the posterior part, but you see the good thing is that the posterior condyles are still intact. So whenever you are encountering these injuries, these fragments, the posterior condyles, are mostly intact. So they are good for your surgical planning. And when we see from the lateral side, as we have discussed, the lateral side is a bit simple. And as we go more posteriorly, we see there is comminution in this part, but this is not important because this part is not in the weight bearing zone. Anteriorly, same kind of picture that we have seen here is visible. So the potential issues in such fractures is that what all components need to be fixed, because there are several fragments. Do we need to fix everything? There are definitely implant related issues because these fractures are quite low. Conventionally, we don't have implants available for these kind of small fragments. The 4.5 mm plate is available for the lateral side and it covers mostly this zone. The posterior part remains deficient, and on the medial side also we have plate, but again it is not able to cover whole of this zone. That means some kind of fixation is required which will cover whole of this zone. And what are the surgical approaches? Because you see there are multiple fragments on both sides, so probably one approach may not be sufficient. And what should be the rehab? Sometimes a surgeon is scared whether to start the movements or not, whether the fixation may fail early or not. So we'll be discussing that also. So in this case we went for dual approach. Why? Because you see we have to address the component on both sides, and I told you that the posterior condyles can act as template for fixation of remaining part of the condyle. So better to start fixation from the posterior to anterior. That's why when we go with a single approach, we will face difficulty in going either posteromedial or posterolateral. So dual approach is good one, because with dual approach you'll be able to address the posteromedial and medial, and also on the lateral side incision you can approach the lateral side and the posterolateral side as well. So it's better to go with dual approach when you want exposure of both posterolateral, posteromedial and lateral and medial sides. Now I told you this part is important, so this part can act as like a template for the remaining condyle. So what we did, we focused on the posterior side. The posterolateral side is simple, so first that was fixed with multiple K-wires and checked under C-arm, and when that was reduced, we reduced the medial condyle also with multiple K-wires and again checked under C-arm. So this was done simultaneously with dual incision, one on the medial side and one on the lateral side. Now you see here, with the help of clamps we have reduced these spikes with remaining part of the metaphysis. So reduction of these spikes is critical. That can be seen in C-arm. There should not be any overriding in this zone. Minor translation can still be accepted, but definitely there should not be any shortening, like this fragment should not lie somewhere here like this, otherwise there will be malreduction on the articular side as well. So once you are sure about the reduction, you need a good buttress plate on the posterolateral and posteromedial side. Why? Because this spike will tend to open up. We have to neutralize all the forces on this spike. So a posterolateral plate can be placed first. You can use a recon locking plate because that is easily moldable and can be placed on any flat surface. So we had placed a plate on the posterolateral ridge like this, and that was able to contain this spike. So this plate has effectively buttressed this posterolateral spike, and we had added a terminal screw also so that it remains more stable. Now we focus our attention on the medial side, and same kind of fixation was done. So you see now we have reduced both posteromedial and posterolateral ridges. Now you see the reduction appears to be good. By just reduction of these ridges, you'll be able to do half of your work, because if you see the bone quality of these ridges, the bone is very thick here. They are actually kind of pillars that are supporting the femur. So we have to reduce and stabilize these ridges so that everything remains stable. Once we had got the template from the posterior side, we started reducing the remaining fragments. You see here, we then tried with multiple K-wires, we reduced the lateral side, and with multiple K-wires, we tried to reduce the medial side as well. Now it's up to you which plate you want to place first. So once we had reduced everything, like you see here, everything appears to be reduced. These condyles and everything were reduced. Then we had placed a plate on the lateral side. Why? Because the lateral side plate is more stronger and the lateral side fracture is more simple. So these screws are the large profile screws. So they are going to add stability to your construct. So now we are done with 3 plates. That means one posteromedial, one posterolateral, and one lateral side. Now when you are putting these screws, you have to see the medial side as well. That means when you are putting these screws, you should ensure that any screw should not be displacing the fragments that you have reduced here, and if that is happening, you have to remove that screw or shorten it so that it is not hampering the reduction on this side. Now we are done with the reduction of most of the side, but we have to still stabilize on the medial side. Medial side is extensively comminuted, but the problem is what implant to be used. So it is kind of a proximal tibia fracture which has extensive comminution and multiple depressed fragments. So we need a kind of raft construct that will be able to support all these fragments in line. So we want screw somewhere here, we want a screw somewhere here, and we want a screw somewhere here, and as multiple screws are placed, it will be good. So the option is that we can use the ipsilateral anterolateral plate of proximal tibia for the distal part of the medial condyle of femur. So you see here we have good draft, and also the contour of the plate can be easily placed over the medial condyle. The medial condyle is prominent like this, and this part you see closely matches with the shape of anterolateral surface of the proximal tibia. So we use the anterolateral surface proximal tibia plate on the medial side. Now the screws that have been placed here need not to be long one, because the purpose of these screws is only to support this comminuted, or you can say impacted, depressed fragment, so that it does not get depressed further and it does not get impacted further. So a good draft has been placed here, and this is the lateral view. You see all these screws, they are supporting the medial side comminution zone. So this was the comminuted zone, these screws are supporting this zone. So we are now sure that we have fixed everything. Now the concerns will be there, that some people will definitely say that it is too much of hardware, the bone is not visible clearly. That means you have replaced most of the bone with the screws and plate, but that is not the thing. See, in articular fractures, the clear principle is that you need to have absolute stability in the articular zone. Otherwise there will be problem in healing, because the cartilaginous fragment will not be stable and their healing will definitely get compromised. For cartilage healing, you need a good concurrent reduction. If the reduction becomes non-concurrent, the healing will be impaired. Even if you have to put multiple screws in the articular zone, then you have to put it. Otherwise you are compromising the stability. And also, if the stability is compromised, the patient will have difficulty in the movements. The moment the patient will bend his knee, he will experience pain because of excessive motion of the articular fragments, and that may actually result in early stiffness and later on fibrosis around the joint. While for the metaphysical comminution, you can definitely go for relative stability, because there we want the functional alignment, not the anatomical reduction. So we are now satisfied with the stability of our construct irrespective of the hardware. So because of this stability, you see the post-operative radiographs, everything appears to be stable. And this part, the comminuted zone, we had not addressed this part. The void is still there, because it is in the notch part and probably non-weight bearing. That's why we avoided any overstuffing in this zone. The comminution was extensive and we didn't do anything. We just removed any prominent fragments in this zone, otherwise they will result in loose body formation. So we were confident, and the patient started range of motion early, and by 1 week he was able to do 90 degree of movements post-operatively. And this was the 6-month follow-up radiograph of this patient. You see the remodeling is still happening on the medial side. Everything is united and remodeling is still happening on the articular side. So even the articular side remodels if you have reduced it properly. The important thing is that you have to reduce the fragments well, and they should be stably fixed. And here in the notch part, we are not sure what is happening, but the patient has reasonably good movement. He has almost 130 degree flexion and full extension. Now the problem the patient had is the implant prominence. So the too much of hardware is definitely a problem, but the stability should not be compromised. So the patient had complaints of impingement on the lateral side. So you see the plate on the lateral side is a large profile plate, so that is definitely going to cause impingement in some patients, especially the lean patients. So we performed the implant removal at 1 year follow-up, and the patient was asking whether the medial side plates can also be removed. But you see here, when we remove everything, we are probably creating a lot of voids, so that can result in stress riser and a fracture. So we counseled the patient for the removal of lateral side implants only. So we removed the posterolateral plate and the lateral plate, and this was the post-operative radiograph after implant removal. And we were concerned about the comminution in this zone from the starting, and we wanted to see what happened to this void. And when we checked intraoperatively, we found that it has been filled with smooth cartilage. You see this part has been filled with smooth cartilage. So probably some kind of fibrocartilage has been formed in this zone, and that void is appearing only on the x-ray, and physically it is not there. And you see at 1 year the remodeling of the medial side is still happening. It has now become very smooth. Earlier there was some irregularity seen here, but now it has become more smoother. So it is an ongoing process. You need to have good stability, and movements should be started as early as possible, because actually the movements help in healing of the cartilage. It allows lubrication of the joint as well, and it allows the healing of the cartilage as well. So you see the patient now had almost very good movement even after 1 week of implant removal. You see here the stitches are still present and the patient is able to bend it more compared to the previous status. So the patient was now satisfied, and now he was not asking for removal of the medial side plate because the problem was actually from the lateral side plate and there was no impingement now. So again the same concern, do we really need these many plates? So this is an example. Here you see there is similar kind of fracture pattern. There is extensive comminution on the articular zone, but the surgeon has tried to be biological. He had tried to plate on the lateral side and fix these fragments with multiple headless cancel screws. Again, I told you the part here, this part has not been utilized with any plate. So ultimately this was the outcome. Now if you see this fragment, these ridges are kind of pillars. If you don't stabilize them, they are going to displace. They are the insertion point of the gastrocnemius, and also the forces are directly transmitted to these condyles when the patient bears weight. So you have to put some kind of neutralization implant in this zone so that the shear forces are neutralized like this. So whenever you are addressing Hoffa's fracture in case of comminuted lower distal femur fractures, always fix them with some kind of plate. The screws may not be sufficient. And when these fragments are very small and completely intra-articular, then the placement of plate may not be feasible. Then you have to put the headless cancel screws only for fixation of these fragments. But the forces now will not be the one which were there earlier. Why? Because the insertion of the gastrocnemius is up till here, and when the fragment is quite small and posterior, there is no insertion of any muscle over this part. So this fragment is still stable even when screws are placed, and the forces that are transmitted to this fragment are absorbed by the remaining intact part of the condyle. So this part is actually not having that much stress as compared to this fragment with a posteromedial or posterolateral spike. So spikes on the posterior side should best be neutralized, otherwise they will have tendency to displace. Another patient you'd see, again the surgeon tried to be biological by just putting 2 plates. He avoided placement of any plate in this zone. Now you see the outcome. I told you the forces are high on this zone. If you are not addressing these components, they will displace. So the same thing happened. The plate remained in place, but the posterior condyle has displaced. So the spikes need to be neutralized with some kind of a stable fixation. And there are some concerns how to place the plate so much posterior, because you have the insertion of gastrocnemius here, and also you have the risk of neurovascular structure which are lying close to the notch part. So some safety concerns are definitely there. So biomechanically you need not to place the plate directly posterior. You can place the plate directly over the ridge. Like I've shown you here in this image, these plates are not placed on the posterior surface. They are placed on the posteromedial and posterolateral ridges. So fixation on these ridges is equally good, and you need not to erase the muscle over the spikes to place the plate. So just place the plate over the bony ridge that you are feeling. No need to dissect so much tissue that can hamper the vascularity of the condylar fragments, and also you need not to detach any muscle. So one safety marker on the medial side is the adductor tubercle. So you need not to go deep to the adductor tubercle. You can just remain over the adductor tubercle. You need not to go till here. You can just keep your plate somewhere here, and adductor tubercle will be somewhere like here. So your plate will be just medial to the adductor tubercle. It will not be deep to it. So that will be sufficient. So just small take home message from this presentation is to identify the displacing forces whenever you are addressing low distal femur fractures. So every fragment that has displaced is bearing some kind of force. So you have to neutralize that. You have to see what is the direction of displacement, and in that direction you have to place an anti-glide or buttress plate. And you have to do something more than reduction. That means reduction needs a stable fixation as well. If you reduce it perfectly but you have not placed stable fixation, that means there will be chances of loss of reduction in follow-up. And the principle is clear that there should be a rigid periarticular construct. The metaphyseal combination can be addressed with relative stability, but for periarticular zone you need absolute stability. And screws alone for addressal of Hoffa's fragment in low fractures may not be sufficient. The screws may keep the reduction safe for some time, but as the patient starts movements, the forces will be high and the screws may not be able to secure the reduction for prolonged period. So better to use some kind of locking plate, like locking recon plate is a good option. And you have to start early range of motion because that actually helps in healing of the cartilage, the lubrication of the joint, and also it helps in the remodeling that will happen in this zone. You see these voids, they all remodel. So whenever the reduction is good, stable and smooth, they will fill up with good hyaline cartilage, not the fibrocartilage. So early range of motion is equally good, and that will be permitted only when you have stable fixation. So you have to maintain a balance between biomechanics and biology. For biomechanics, you have to go for a well stable construct, and as far as biology is concerned, you have to preserve the soft tissue attachments, you have to avoid any erasing of the muscle insertion, and you have to avoid any excessive periosteal stripping. I think that will be sufficient. Even when you place multiple hardware, the fixation will remain biological. So thank you for listening. If you have any queries, you can just put those in comments. Thanks again.